All right, well, good afternoon, everyone, and welcome to our Multi-Modality Imaging Conference. My name is Chamsi-Pasha, and today's task is going to be talking about cardiac CT and cardiac MRI artifacts. This is the QR code for you guys to scan for recording attendance. We're going to pause here until everyone grab their phones and snapshot. All right, John Michel, is this moving or is this it's an illusion or an artifact?
It's moving, but it's not moving.
If you focus at every circle, it's actually pretty stationary, but when your eye basically looks at all these multiple circles en route, you're gonna give the illusion that they're moving. So these are all stationary circles and none of them are moving. So let's talk about the cardiac CT and basically what are some of the artifacts that we are gonna see during cardiac CT. It's not about whether you are gonna see it or not. The answer is you are gonna see those artifacts, and the question is what causes them. So really motion artifact is the most common artifact that we see in cardiac CT. Typically respiratory motion is one of the things that can happen if the patient are not able to hold their breath. And then number two, motion of the heart itself and motion of the coronary arteries. When does this happen? If the patient has an irregular heart rate, if the patient is tachycardic, so the heart rate is fast, or if the patient has any arrhythmias, whether sinus, ventricular, or atrial arrhythmias. If we go back and think, how are the images acquired? Typically, we ask the patient to hold their breath because we want to minimize respiratory motion. And number two, we time our acquisition during the diastasis period. So by definition, this is going to be the mid to late diastole, because this is the time when the coronary arteries are filling with blood, and this is the time when the coronary arteries are the largest and the least motion. Hence the need for heart rate lowering or beta blocker in our cardiac CT acquisitions. So this is a standard prospective ECG gated cardiac CT acquisition. Patient on the table. Every time the camera rotates around the patient, it's generating an image or acquiring a scan, and then the table is going to move, so you're going to skip 1 hour interval, then you're going to rotate and generate an image, and then it's going to move and then rotate and generate an image. So notice over here, the acquisition window is in that mid to late diastole, so somewhere around 70 to 80% of your RR interval. And I need that heart rate to be regular, and I need that heart rate to be slow. This diagram or this figure shows you on the x-axis the phases of the cardiac cycle, and on the y-axis the velocity of every individual coronary artery. So in red, you're going to see the RCA, which basically has the highest motion or highest speed among all coronary arteries. And typically once you approach that 90% RR interval, that's where the P wave kicks in. So once you have an atrial kick, notice how significant increase in the velocity of the RCA. The same thing basically is going to be during the systolic period, which is the 10 to 20%. So what we're trying to say basically is that what period of the cardiac cycle do all three coronary arteries has the least motion? I hope you agree with me, but the the nadir over here of all these three segments is around that 70 to 80%. That's the sweet spot. That's the mid diastole that the coronaries have less motion. And if you take a look at this other phase in the cardiac cycle, between that 30 to 40% phase, the coronaries also are in a quiescent phase, so they have less motion. And I'm going to use this quote-unquote isovolemic relaxation time by definition after the aortic valve closes, before the mitral valve open, to acquire my images. So patients with slow heart rate image in mid to late diastole, or 70 to 80% of the RR interval. Patients with faster heart rate use your systolic imaging acquisition. This is what I need to get. This is a sagittal view. Here's the right coronary cusp. Here's the RCA. I want to be able to generate an image and freeze the motion of those coronaries and get a motionless right coronary artery. Which is why every time I'm asking my techs and my fellows to look at a post-scan, I need to do some quality checks. One of the quality checks I need to see is what's happening to my right coronary artery. Here's the right coronary artery as it comes off on the axial slice. You have this winging appearance, or some people call those black halos around the vessel. And the reason why you're not seeing a nice contour of the RCA, because there is coronary motion. And that is because this patient, when we image them, their heart rate was actually fast. So if we go to the second slide over here, this is what the aorta looks like. Here's the the right cusp. Here's the proximal and the mid right coronary artery, and it's not interpretable. I don't have a good edge definition. I have a moving artery. That's exactly what it is. And the reason behind that, because when I acquired my images over here, I didn't acquire it in this mid diastole or after the T wave. I acquired it over the P wave. So I was around 450 milliseconds after the R wave, at the atrial kick. If I actually now move my acquisition a little bit shorter, so meaning that I'm gonna actually see, here's my R wave. Let's say this heart rate is 60 beats per minute, then technically you have 1,000 milliseconds between this R and this R. What I'm gonna tell the scanner is that see this R wave over here, and then start acquiring images 200 milliseconds after. So you're gonna be somewhere over here from the beginning of the T wave till the end of the T wave. Do you see this line? This is my systolic image. And this is during the isovolemic relaxation time. Same patient, different phases of the cardiac cycle. Now I can nicely see the lumen, and I do not see any motion here. I cannot assess the lumen. Why? Because I have so much coronary motion in this patient who has a fast heart rate. This is basically another example of what coronary motion artifact looks like. Here's the volume rendered image of the heart. Here's the proximal RCA. All of a sudden, you start seeing a break within this vessel. There's blurriness, and then there is a lot of winging appearance. This is what an artery that's not moving should look like. So this is the most common abnormality that we see is coronary motion artifact, because irregular heartbeats or fast heartbeats. Now this is another example. Here's an axial images of the heart. Here's the aorta, here's the pulmonary artery. This is the left atrium over here. I hope you agree with me, but there's almost like kind of double edges across the septum. There are double edges across the aorta. Do you see over here? There are kind of two lumens that are happening. And the reason behind that, because if my images, I'm not actually fast enough in order to freeze the motion of the heart, this is what you're gonna get. You're gonna get a blurriness or a motion artifact. So this is basically what a shutter speed looks like. If I'm acquiring a frame per 100 seconds, then I'm gonna be able to get a perfect motion-free image. But if let's say I'm acquiring an image every 15 seconds, then this apple or this period that has actually moved from one place to another, my speed of acquisition was not fast enough in order to freeze the motion. So this is where we talk about the temporal resolution of the cardiac scan, which is the time it acquires to generate an image. Typically in our newer generation scanner, it's around 62 milliseconds. But this is exactly what you see with cardiac motion. Let me show you other images over here. This is a sagittal view. This is the ascending aorta. There's almost like kind of, people might say, is this a flap? Why do you have double edges over here? Why do I have double edges in the left atrium? Why do I have double edges in the ventricle? The same thing over here with the left atrium. You do not have a distinct border. And the reason behind that, because this patient, when they showed up to the CT lab, they were in atrial flutter. You see this nice sawtooth appearance. And when I acquired my images, the heart was in a different phase when I acquired the images. Hence, there was cardiac motion in this patient. Because notice how the ejection period is actually variable and the diastolic period is variable. So over here, this is over the T wave. This one here is a little bit shorter. This one here is a little bit after. So this is what cardiac motion artifact looks like. Now the second thing, when I'm doing my routine cardiac CTA, I don't have a volumetric scanner, meaning a scanner that's with one rotation generate all the images. Typically every time the camera rotates around the patient, I get a slab of the heart anywhere between 3 to 4 centimeter. The second time the camera rotates, I get a second slab. And then the third time the camera rotates, I acquire an additional slab. And all these slabs have to be stitched together. So that's why basically these are prospectively gated acquisition, and they take multiple cardiac cycles, 1, 2, 3, 4. So as a result, I basically could be at risk for what we call misregistration artifact. When I put stitch all these slabs together, sometimes basically an artifact can occur which actually will present what we call a step artifact. Take a look at this RCA. Notice how over here it actually jumped from one location to another. Here's the RCA. And then as I'm going down, this vessel actually all of a sudden went down versus it was over here. So why would the vessel jump out? And that's because when I stitched those slabs together, unfortunately it did not co-register well. So that's exactly what people call a step artifact. Here's the RCA over here, the proximal segment, and all of a sudden the vessel is completely in the wrong direction. Here's the RCA over here, and then the second vessel basically went behind it. Why? Because these slabs did not register together, and that happens in patients we're doing a prospective gated acquisition, meaning I'm acquiring multiple beats to generate an image. What is the solution for it is what we call a high pitch scanning. So this is through a Siemens mode by which with one rotation around the patient, I can freeze the heart and generate a motion-free image. So as the table moves fast, here's the beam across the heart. This is the X-ray beam. And then I'm able to kind of, with one beat and one breath hold, I'm able to kind of freeze the heart and get a motion-free image. So this is what a flash mode looks like, or a high-pitch scanning mode. You could see actually all the vessels over here between the LAD and the RCA, they're completely motion-free, and you can significantly lower the radiation in those patients. When do I use it? I use it in patients who I want to avoid these step artifacts. This is another patient who has multiple misregistration artifacts. Take a look at this slab artifact over here. When it's stitched to the second slab, it didn't actually line up. The same thing over here. You actually have almost like kind of a second edge or a second border. The third one over here, the fourth one over here. So the best way to fix those step artifacts is basically you could use one of the scanners in the market, for example, the GE or the Toshiba. We call those wide coverage detectors. So there are so many number of detectors that only takes one RR interval to generate an image. Or we could use through our Siemens scanner the high pitch spiral mode. So the table moves fast, the camera moves once, and then you're able to generate an image, meaning you're not gonna acquire images over multiple cardiac cycles, but instead the images are gonna be generated over one cardiac cycle. Now this is a typical board question. You're gonna face a artifact in a coronary artery. So here's the right coronary artery on this patient. I can see contrast over here, but after that there's blurriness in this segment. And when I take a look at the sternum on this sagittal view, there's a break line in this sternum. When the patient breathes during the acquisition, that's exactly what you're gonna take. And if this slab is running across the coronary artery, in this case the RCA, then yes, you are gonna develop motion. This is not coronary motion, this is respiratory motion artifact. Always practice breath hold. Typically we ask patients to hold their breath during inspiration. They don't have to do a deep inspiration. And more importantly is that if I use a single beat acquisition or a high pitch scanning, it only takes a fraction of a second to generate an image. But if I'm gonna have to wait one cardiac cycle, another cardiac cycle, a third cardiac cycle, it's gonna take at least 6 seconds to be able to kind of do the cardiac scan. These are basically also multiple LiDAR step artifacts where you can see multiple lines or multiple breakage lines across the sternum, consistent with respiratory motion artifact. Now, streak artifacts, or some people call those beam hardening artifacts. So typically think about if you have metal, or if you have calcium, or if you have any quote unquote wire inside the heart. What happens is that the low energy X-rays are being attenuated. So we have high energy and then we have low energy. Once the low energies are basically being averaged out and they're going to be attenuated, what's going to happen is that now the weighted average of your resultant X-ray beam is going to be much harder. Why? Because you have taken away the low energy and now all what you're left with is the high energy. And this X-ray beam, as it's hitting through those metals or wires, it's basically going to create, as it hits those objects, it's basically going to create an artifact. Typically, you're going to see it in clips, pacemaker wire, stents, heavily calcified vessels, or regions with high contrast density. Some people call this beam hardening, some people call it blooming. So here's a stent in the left anterior descending. Notice how inside the stent, things appear black. Again, because the weighted average is basically now more of the higher energy, and as the higher energy goes through the stent, there's basically going to be an artifact of low energy that's being attenuated, and I'm not able to see inside the stent. One of the solutions for this basically is using what we call a sharp kernel. So these are post-processing filters that we apply on our cardiac CT, and notice how now the edge of the stent is actually not blurry. And number two, I don't have this beam hardening artifact going through the stent, and now I can see the contrast flowing inside the stent nicely. So these are basically what you see over here is the type of the filter. This is a body vascular, and the higher the number, the sharper it is, meaning that I can improve my edge definition and I can also see through the stent. While here, I cannot really see through the stent because everything is black. So that's basically one of the solutions for this condition. And nowadays, we have actually even reached to a much higher spatial resolution with applying through those filters. If you look at this stent over here, everything is patent, but over here, there's an area of low attenuation, meaning there's an area of blackness. Right over here, if you appreciate it, this is a 90-degree projection. And the question, is this an artifact or is this a real stenosis? And because the whole stent actually is patent and there is no low attenuation density, we actually did call this a patient with severe in-stent restenosis. And if you take a look at the angiogram over here, here's the RCA stent. You have serial severe high-grade lesions across the stent. So now we're actually able to kind of improve our resolution and decrease our false positive readings for those cases. This is another example of streak artifacts. So here's the patient with a mechanical mitral valve, left atrium, left ventricle. Do you see those black shadows that are being emitted from the valve? That's exactly what are streak artifacts, or some people call those beam hardening artifacts over here in this mechanical mitral valve. This is a patient who has pacemaker leads, including a coronary sinus lead, and you can also see those artifacts, those black arrows or black lines across the pacemaker lead. Blooming artifact is another term for the beam hardening, and again, it basically talks about the same concept. It's basically the attenuation of the low energy, and hence you have a much higher weighted average. And this is the Achilles heel of cardiac CT imaging. If I take a look at this LAD, I have so much calcium that this calcium is actually blooming, and I'm not able to kind of see inside the vessel. Then you can overestimate stenosis in those cases. So thankfully, with the new generation CT technology, something called the photon counting CT, and this is a slide from Dr. Chi that she presented at the Multi-Modality conference, I'm actually now able to kind of see with a much better detector and with a much better signal to noise ratio. I can actually see a patent stent, and I can also see, take a look at this stent over here that has a very large amount of plaque that's actually growing in this RCA. Here's a plaque that's actually protruding into the stent, and it's causing almost a near complete obliteration. So now the technology has actually improved. Now we actually have a much lower, a much better spatial resolution. We can image patients at 0.2 millimeter, because the thinner the slices, the better the resolution that I can get in my patients. This is a concept of explaining why does calcium overestimate stenosis and why does it bloom. The concept of partial volume averaging is that you have different properties within one slab or within one voxel. It's contained within the same image, but each one has a different weighted average, meaning that each one is going to attenuate the X-ray beams differently. So if you take a look at this schematic diagram, you have basically voxels that are in, or pixels that are in orange, and then you have pixels that are in purple. If the purple has a much higher weighted average, for example, calcium, it has a much higher Hounsfield unit compared to others. What happens when I take a look at it across the z-axis, so that's going to be your through plane, not the end plane, is that you're going to end up with basically a color that's mixed between purple and, let's say, light purple. So again, what's happening with calcium is that it's not only occupying the pixel that it's sitting in, but it's also averaging out the adjacent pixels. Hence, it actually takes more space than it should, and hence it actually renders our diagnostic capability when we do cardiac CT imaging. So remember, calcium is your Achilles heel of cardiac CT. We're hoping with the new generation scanners and the better detector coverage and lower resolution is that we can actually mitigate some of that artifact that we see. As Dr. Mamarian kind of talked in his basic CT talk, is basically the CAT scan is an X-ray emitter, and then basically there's a flux of photons that have to penetrate through the patient. So if I have actually low photon flux, notice how over here you have like kind of this sand and pepper appearance. So that's basically what noise looks like on CT. Remember, you have signal and you have noise. You always want to make better signal, lower noise in your patients. So notice how this image over here is smoother compared to this image over here that's noisier. Typically with the larger the body habitus, the more distance that these photons have to penetrate through the patient. So one of the solutions that we do is basically we rank up the voltage of the X-ray tube or the current. So this is basically the photon flux or the energy that's being delivered through the patient. And number two, you can actually make the slices thicker. For example, over here I have noisy image, and over here I just thickened up the slice. You might have decreased your resolution, but at least you improve your signal to noise ratio, because the thicker the slice, the lower the noise. And then last is the soft reconstruction filters that can help make an image better. So these are also some of the post-quality checks that I do on my patients after a cardiac CT. Look for coronary motion, look for respiratory motion, and then look for any noise within the cardiac CT images. Now, the next half of the talk, we're going to talk about some cardiac MRI artifacts, and we kind of segregate them into categories. Similar to how we see and we encounter motion in the cardiac CT, we can also encounter it in the cardiac MRI. If the patient moves or since the heart, if you have any respiratory motion, so the patient is not able to hold his breath. If I have a problem with the ECG gating, either because the patient is in an irregular heart rhythm or the patient is having multiple extra heartbeats, I'm not able to properly gate those ECGs. There are some other artifacts that we see because of the flow of the blood. So these are some of the flow artifacts and the motion of the blood inside the vessels. Hardware, so that's basically similar to your metallic artifact that we see on CT. And then basically we're going to touch base about other inherent physics and phase wrap artifacts. These are some of the good references that you can come across in order to learn more about the MRI artifacts. And it's a hot topic that they like to ask and test people on the boards. The simple thing, this is a sagittal view on cardiac MRI. So we can see the left ventricle is over here, the right ventricle over here. But the images are motiony. And the question is this motion because of cardiac motion? Meaning that the patient is having an extra heartbeat or an arrhythmia, or is this because of respiratory motion? So typically the goal is to look at the motion. Is it only at the heart and the lung, or is it you also see it in the abdominal viscera? And when you start seeing the abdominal viscera also appears blurry, then this is typically what patients, when they breathe in during the scan, that's exactly what you're going to see. You're going to see the whole image, including the intrathoracic and the abdominal viscera are going to be blurry in this case. So some of the solutions basically to try to minimize breathing artifacts is I can shorten the acquisition time, meaning that I can acquire more lines per cardiac cycle, or we call these volumes per second. Sometimes if I decrease the number of the K-space lines, so this is how we generate an image. We have to fill in certain lines inside that K-space in order to generate an image. And then worst case scenario, if the patient is not able to hold his breath, I'm just going to do a real-time acquisition, similar to how you do an echocardiogram, which is also a real-time image. But we try to kind of go and troubleshoot all of these before we say that, oh, I cannot really kind of continue. The patient is not able to hold his breath. On MRI versus CT, obviously the images are basically acquired in segments across multiple cardiac cycles. And typically, because we want to see the heart moving in systole and diastole, these are what we call a retrospective gated acquisition. And that's basically the most common mode of acquisition. So meaning, I'm actually between the R wave and the R wave, I have certain bins and certain phases of the cardiac cycle. Typically, we want to get at least 25 phases in order to improve our temporal resolution. And notice that we have this quote-unquote K-space, which is kind of the center of all the end result of the radio frequency pulses that are being sent and collected. Notice that you start filling lines of data. So you do it basically in every phase. I'm filling lines, and then the second RR interval, you're going to add on and to fill more lines of data. Why? Because now you're going to go from having images from end diastole, which is around 0 milliseconds, all the way to the next cardiac cycle, and you're going to be able to kind of see that in motion. So when we talk about retrospective versus prospective, so the retrospective gating, there is no loss of data from one R wave to another R wave. But in a prospective gated acquisition, similar to a CT, I tell the scanner, here's the R wave, and then I want you to start, for example, acquiring images either during systole or during diastole, so you can time it based on the period of the cardiac cycle that you are interested in. So this is what retrospective versus prospective gating looks like, and the same thing applies on CT and on MRI. If I have a patient who's basically having PVCs and I'm actually having a lot of cardiac motion, that's exactly what you're going to see in a patient with arrhythmia artifacts. We do have some inherent in our scanners, some rejection, meaning, but every time you're rejecting a beat, you're prolonging the acquisition. But this is exactly what you're going to see. You're going to see a blurry image, and that is basically due to an underlying either atrial or ventricular arrhythmias. If I have a patient with atrial arrhythmias and I'm doing a retrospective acquisition, meaning that the RR interval is so variable, and then the heart, sometimes it's in end diastole, sometimes it's in end systole because of the variable RR interval. If you're trying to image someone with atrial fibrillation, then typically what you would do is you would do a prospective gated acquisition. So you time it basically to the R wave, and then you're only going to acquire images during systole, so you're going to get a true end systolic image, but you're going to omit the diastolic image. Why? Because the RR interval is variable, but my systolic ejection period is usually fixed and unchanged between the RR intervals. So while your diastolic filling period is different, your systolic ejection period is usually the same. So notice how this image over here is much better. I have a much better signal to noise ratio. The edge definition is better. You're going to get a true systolic function because you have the end systolic volume. You might underestimate your end diastolic volume because you don't have that peak R wave or the end diastole in those cases. Another kind of artifact is what we call an aliasing or a phase wrap artifact. So this is basically when we have parts of the body that are outside the field of view. So remember, the field of view is basically what you designate that you want to acquire images in. And these, what happened is that they start to become wrapped around to the opposite side of the image. So if I'm actually I set a rectangular field of view that's actually smaller than all my body region that I'm actually is inside the magnet, then basically this is going to lead to an artifact. Typically what we do in those cases, we try to kind of maximize our field of view because we do not want to have this wrap. And the other thing is that we also try, because when we acquire images, we're also acquiring gradients across that phase encoding direction. And if I basically encode in that shortest anatomical direction, I'm going to be able to minimize. This is exactly what we're talking about. So this is a very wide field of view. This is going to be a coronal image. So you see the ascending aorta. And what's happening over here is that the opposite subcutaneous tissue over here is actually wrapping around the heart. I don't know if you appreciate this over here, but that's not a normal structure because the field of view in this case, I've actually set it to be smaller than the whole extent of my radio frequency pulses. So typically what you need to do in these cases, you want to basically increase that field of view. Take a look at the opposite tissue over here, or the hand in this case, or the arm is actually wrapped across this field of view, and you have wrapping here and an artifact here. And then once you increase that field of view, you're going to actually decrease that artifact in this case scenario. The second thing that we can also actually see those wrap artifacts, do you see those lines? Actually, these lines basically can sometimes wrap around the heart. And if I'm doing a late gadolinium enhancement sequence, they can actually create an area of high signal intensity. So all of this is a scar imaging. So black is normal and then white is dead. So if you see these white areas that are going across the heart, this is basically not because the patient has a scar tissue, but unfortunately you're having a wrap artifact that's basically protruding over the heart from the opposite tissue because of the pitfalls that we talked about. The steady state free precession is basically the main power horse where we do our cardiac MRI images. We actually are prone because these basically protons are being continuously flipped in opposite directions, and they are also repeating themselves. That's how they generate an image because of the resonance that they generate. So what happens basically in those artifacts is that those protons that are spinning, they actually start to become out of phase. So you want the protons to be lined up in one direction in order to basically minimize any what we call dephasing. But unfortunately, some of those protons could be spinning at a different speed compared to others. And typically, the higher the magnetic field strength, the more likely that you're going to see those artifacts. We call those areas of banding artifacts, and I'm going to show you what they look like. But anytime there's any perturbation of the magnetic field, that's exactly what you're going to see. So the idea is that you always wanted to kind of apply special types of coils. We call those shimming coils across the heart or the area that you want to image. And at the same time, you might want to minimize your repetition time because every time you're repeating the same sequence, you're actually generating more artifact. So this is basically is a case where I'm imaging a heart, but notice over here, the heart actually has a lot of inhomogeneity. This field or this image is actually very disturbed. Is that right? So why are there black areas and there are white areas? It should be like this. So what's happening is that there is a lot of dephasing, meaning that the protons are not subjected to a homogeneous magnetic field, but instead there is a lot of inhomogeneity. And then once you apply those shimming coils, the same image now starts to become crisper, and you have a better signal to noise ratio in these cases. So that's exactly what it looks like without the shimming and then with the shimming. These are the other artifacts that we were talking about, the banding artifacts. So do you see basically there are those black lines that are actually out in the stationary tissue? And that's again because the further out where you have the center of the magnetic field, you're more likely to see those lines, and that's basically because of the dephasing that happens. And typically it's going to occur in those stationary tissues that are near the edge of your field of view. So here's a rectangular field of view from here to here. Near that edge of it, with the further out you're from the center of the magnetic field, the more likely you're going to have those banding artifacts. We have another type of artifact which is basically affected by flow. So if you take a look at this is a short axis of the aortic valve. I cannot really tell whether this patient has a bicuspid valve or not. Probably looks like it. This is the left cusp, this is the right cusp, this is the non-cusp. But there is a lot of pulsation or pulsatile flow going in through this valve. So this is using the standard steady state free precession. And if I actually just apply a different gradient, a different pulse sequence. We call this the spoiled gradient echo. The same image right now, you have a much better edge definition, and you have actually less pulsatile artifact or flow artifact. So now you can definitely say that this is a bicuspid valve. Why? Because you're less susceptible to disturbance of flow that typically these patients would have if you use the standard SSFP. Also, if I reduce my repetition time, so basically I want to try to kind of generate a less of a disturbance of the signal. And then also if you increase the bandwidth, so meaning that you're collecting more on your frequency encoding frequencies, that's also going to generate a less artifact. And then the third thing, if you decrease the number of the case space lines or the segments, that also can hope to decrease some of that pulsatile flow. Here's a signal loss that you're seeing. This is the left atrium, and you start seeing flow from the pulmonary veins. And that's also related to the steady state free precession, because it's actually susceptible to disturbance of flow, and it's also susceptible to inhomogeneity in the magnetic field. So what you're seeing over here is the protons that are dephasing in different directions, and that's why they're following the column of blood, and that's why you're seeing this loss of signal in these cases. This is another patient with a Cine SSFP of the heart, and what you're seeing down here, basically up here, is actually the shading or the banding artifacts. Again, it's not affecting my heart field of view, but you could see actually how this could basically create an interference if you're not imaging the heart in these cases. One other artifact that we typically see in our first pass perfusion, so this is basically gadolinium going inside the heart, and you see actually over here there's a small area of a 1 pixel of a dark or low signal intensity versus an area over here that appears to be very dark and it persists during the cardiac cycle. So how do I differentiate between a dark rim or a Gibbs artifact from a true perfusion defect? Typically this Gibbs artifact, which is believed to be due to volume averaging, again, if you have a high contrast load and then you have a moment or you have a piece of the myocardium that's in that intersection or that boundary between the high contrast and the heart, the contrast of the heart basically might cause a signal loss in that area. Why? Because all the signal starts to become averaged. This contrast load can also create what we call a susceptibility effect, meaning that it also generates a signal loss, and that's why you see this dark area right over here. You see it right over here? This is basically what an artifact looks like, and typically it doesn't last more than 3 to 5 cycles. But if it does last longer, like take a look at this area, it's much denser, it's more than 1 pixel, and it lasts longer. This is a true perfusion defect. So you do not want to call this a perfusion defect, but you want to call this a perfusion defect in this patient that you're doing a stress MRI on. Metal artifact, basically we know that in MRI we generate images from hydrogen atoms as they are subjected to a radio frequency pulse and a magnetic field. They're basically going to start to spin, while metal does not really have any a hydrogen atom in it, so basically it's going to create this what we call susceptibility or signal loss artifact. So this is a patient with sternotomy wires. This is a patient with a radio frequency because he has a pacemaker generator. And you can see actually how there's a lot of high signal intensities and low signal intensities in those patients. In this case, we do not use a SSFP sequence. Why? Because the SSFP sequence is very susceptible to inhomogeneity of the magnetic field. If I have a pacemaker, that's basically going to create a lot of inhomogeneity. So in these cases, we typically reserve to a gradient echo in order to acquire my LV volumes. Sometimes, in rare case scenarios, sometimes you might want to raise the arms up if the pacemaker is close to the heart. Sometimes you might want to image with the arms up to kind of move this pacemaker away from the heart field of view. And then rare case scenarios where you actually might want to gently kind of see if the pacemaker generator might be pushed up against the chest. But pacemakers are safe, but the problem is you are going to go through artifacts, and this is where the tech is usually on the lookout for those, and always optimizing your image quality in order to make sure that you have a diagnostic image. These are 2 cases of late gadolinium enhancement, and what we're looking at basically is what we call ghosting artifact. Do you see this line going from here all the way down to here? Do you see there are a very subtle line over here, and there is another line that's going up and down? So when the artifact is due to a improper ECG gating, so meaning that the patient is having an extra heartbeat or they have an irregular RR interval, typically it's only going to affect the cavity of the heart. But once the patient does not hold his breath, you're going to see this ghosting artifact going across the adipose tissue. So here it goes across the lung, here it goes across the adipose tissue, so you know that this is more likely to be a ghosting artifact from here to here and not related to an underlying gadolinium uptake. whenever we basically see some of those arrhythmias artifacts, so this one here is only affecting the heart, is that right? We see that motion or we see that band, but only in the heart. So we know that this is a gating problem. And instead of basically acquiring the images every one heart cycle, you could actually wait another heart cycle, so skip one beat, and then start collecting your T1 weighted image, and you see the same patient, you can actually get a quote unquote, a adequate study with no artifact that is related to cardiac arrhythmias. For the sake of time, I'm not going to go over the T1 time, but for the chemical shift artifact, this is something that we commonly see and encounter. And the reason behind that, because there's going to be hydrogen atoms in waters and hydrogen atoms in fat, but typically when they are inside the magnetic field, typically they're going to spin at different frequencies, and the cutoff is basically 3.5 parts per million. So what happens is that some of those pixels, when we look at it at the frequency line, which is your X plane, they actually do not line up and they get misregistered, meaning that if the fat and the water are lining up in the same pixel, you might actually have a different frequency. Why? Because they're not spinning at the same time. Hence, you actually end up generating a loss of signal, or one signal cancels the other. So for example, if you take a look over here, this is the endocardium of this RV wall. And then notice over here, you have a small amount of fluid that's actually above the, or anterior to the RV. So what you notice over here, there's a signal loss, there's a black. Why? Because you have now two interfaces. You have basically blood over here, and then you have fat on top, and then you have fluid adjacent to it. So any intersection between fat and water is basically gonna cancel the signal among each other. So here's another epicardial, here's another short axis, here's the RV. You see over here, there's a fluid. There's actually a black signal over here, which is gonna be the parietal pericardium, and then on top of it, you're gonna have the adjacent fat. So the fat-water interface is basically going to create this black artifact, or people call the India ink or the chemical shift artifact. So in conclusion, the knowledge about the appearances of artifacts is essential, because we do not want to misinterpret an image, whether LGE or whether on the CT, but altering the scan parameters and basically making sure that every scan that you do, you look at it and you verify the quality is adequate, yes or no, and if not, what happened during the time of acquisition is really going to be mandatory in these cases. Happy to take any questions. Go ahead.
Thank you so much. Are there any ways to minimize artifact in post-processing? A lot of these were mentioning pre-processing, ways to minimize, but what about once you have an image that already has?
Yes, I think the ones that are now available, not all of them are commercially available, is the motion correction. So you could actually apply a motion correction, quote unquote, sequence, at least in the MRI, that actually might minimize your respiratory motion in those cases. But unfortunately, if you, let's say you have this ghosting artifact on an LGE, or you have a motion artifact on a coronary, there is really kind of less likely that you're going to be able to resolve. Now, it all depends on the cause of the motion. If, let's say, you have multiple phases of the cardiac cycle, one has less motion compared to the other, then yeah, a motion correction algorithm, which now a lot of the scanners do have it also on the CT side, they might actually improve your signal to noise, but they might not eliminate the motion. So I think the degree of the motion, you have to look at it. Is this permissible for the software in order to correct for it, or is it not? Let's say, for example, if someone took a breath in, you're done. You cannot really, there's no motion correction algorithm. But let's say someone has an arrhythmia, or someone has a very subtle coronary motion or a cardiac motion, then some of those machines now, they do have a motion correction algorithm that they might be able to correct for it. All right. If no further questions, thank you for tuning in, and we'll see you next week.